Good afternoon. Welcome everyone to AEI's this year's abbreviated session on the Medicare Trustees Report. As I suspect everyone who has dialed into this meeting knows, the Medicare and Social Security Trustees Reports were released this morning, and we have the honor of welcoming Paul Spitalnic, the Chief Actuary of Medicare, of the Centers for Medicare and Medicaid Services, to this event. This is actually an event that I didn't expect to happen, in the sense that this is one of the rare times when the Medicare Trustees Report has come out on time. In fact, it's actually a day early, technically speaking. The Social Security Act requires, but doesn't penalize, the executive branch if it fails to meet the April 1st deadline. It's March 31st, so we're a day ahead of schedule. Could have been released on Monday, but I'm delighted that it's been released today, and delighted to have Paul here to discuss the Medicare report with us. A few comments about the trustees report. The last time that the Medicare trustees report came in on time was in 2008, and I really didn't expect to see it ever to come in on time again. But you know, there's always next year, Paul. So I'm really optimistic, and I actually think that it probably will come in fairly early next year as well. One last comment: any delay in the release of the trustees report has never been because the actuary's office has been late with anything. They're never late with anything. And so really it's a matter of scheduling the various secretaries of the departments who are the trustees to get together all in the same room for their annual meeting. The actuary's office is never to blame for lateness on this. It's always a matter of scheduling and politics. That said, let me just introduce Paul Spitalnic more formally. He's the CMS chief actuary. And I think it's important to point out that he has two major responsibilities. The one that most people think of when they hear the word actuary is, well, he's responsible for overseeing and collaborating with his colleagues over the technical aspects of the Medicare program. And other aspects of CMS's operation, but people tend to think of this as a very technical job, and it is. But there's another very important aspect of this, which is communications. Paul has the critically important job of trying to get these very complicated ideas across to people in a way that can be appreciated, not just by the public, but importantly by policymakers. And so let's not forget that there's two parts of this job, and Paul's been doing this for a very long time, and so I'm delighted that he can do it again this time. We only have an hour, and I will ask people, if they have questions, to submit their questions to either jack.rowing at aei.org or on Twitter at #AskAEIHealth. And this information is also on the website that announces this event. So with that, Paul, why don't you take it away?
Thanks, Joe. Good afternoon, everybody. Thanks for the kind words, Joe. It is my privilege to represent the work that has done, the work of the Office of the Actuary at the Centers for Medicare and Medicaid Services. Our function is to support the Board of Trustees in their preparation of these critically important reports to Congress that come out annually. but the work is truly done by an amazing team in the CMS Office of the Actuary that I have the privilege to represent and to speak on their behalf. So yes, we have made the date, the statutory date this year. It is a challenge. It is always a challenge to produce and to get this report out. And before you start working on our commitments for next year, Joe, let's get through today and get through today's report before we start making commitments for next year. I will add it's not only just scheduling and conflicts and politics, although sometimes scheduling and other factors have crept in. It's also been some of the delays have just been attributed to Medicare is a space that has a lot of significant legislation. And one of the things that is pretty critical for these reports is to reflect as current as possible what's happening in these programs. These programs, and I'll get to this in my formal presentation in a little bit, these programs have changed a lot. Every so often, 2 or 5 years, there have been some major pieces of legislation that have drastically changed these programs. To the extent that those might happen, very late in the year or very early in the year, those can often affect the production of these reports. And it is clear that the Board of Trustees do not want to release a report and it be, out of date, the day it was released. So a lot of times in the past, some of those delays have been because of major legislation that just needs to be incorporated. I'm going to start a formal presentation, and Joe kind of set the expectations rather high in my ability to communicate these complicated topics, but I'll do my best to get through the key points of the 2023 Trustees Report. So just going to walk through, I like to start these presentations by just having a current snapshot and how we've gotten here of the Medicare program. We'll go over some of the high-level reports. This year in particular, there have been some key modeling changes that I'll at least allude to, if not get into a little more detail throughout the presentation. I'll walk through the detailed results and then some additional material that'll supplement some of those modeling changes that I'm referring to. So I'd like to start with overview of Medicare. Medicare is comprised of, is funded through 2 separate trust funds, the Hospital Insurance Trust Fund and the Supplementary Medical Insurance Trust Fund. Within SMI, there are 2 distinct accounts, Part B and Part D. All of these funds and accounts are distinct. There's no ability to shift dollars across them, so they each need to be funded adequately individually. Not only that, but they are funded uniquely, each of these funds. And so as we go through, the trustees have to analyze and present the financial situation of each of these trust funds, and they are somewhat unique. The broad context, Part A, generally pays for inpatient skilled nursing, home health, hospice care, basically institutionalized care from an institutional setting. Part B is generally outpatient services, so physician, outpatient hospital, physician administered drugs, and some testing and other supplies. That's Part B. Part D is the prescription drug program. There is somewhat different, unique characteristics across the enrollment across these programs. The SMI are distinct in that there are premiums required in order to get those services, and that's why we typically see a little bit lower enrollment in those programs. Turning to the financing, HI is financed through payroll taxes. So amounts that are deducted from workers' paychecks on a weekly, monthly basis get deposited into the trust fund. 2.9% of all earnings, and then an additional 0.9% for high income earners. In addition, there's also a share of taxation on Social Security benefits gets deposited into the HI Trust Fund. The HI Trust Fund, that's the one that is effectively the one that where reserves are built up and where the most focus on depletion dates are typically discussed, because to the extent that these revenues, including accumulated reserves, are inadequate, if they become inadequate to provide benefits, then full benefits would not necessarily be able to be paid. On the B and the D side, there are monthly premiums. B is set on an annual basis, same Part B premium for every beneficiary. And generally speaking, the premium is set to be about 25% of the total cost of Part B, with the government contribution filling in the balance. There's a little bit of other stuff that gets in there, but doesn't move the needle all that much. We'll see it on a different slide. On the Part D side, these are provided by private plans, and so each of those private plans have different premiums, but the way those premiums are calculated is through a base beneficiary premium, basically establishing the national average of roughly 25.5% is paid for through these premiums. To give a context on the size, expenditures in 2022, 343 billion in Part A, 437 in Part B, 126 billion in Part D. Billion here, billion there. Pretty soon you'll start talking about some real numbers. Importantly, what I like to present this each year to highlight a couple of main points. One thing that happens in these reports are there are short-term and long-range projections. The short range usually looks out about 10 years. The long-range projections look out 75 years, and there's even infinite horizon, but those do not get a lot of attention. One of the points of these slides is to describe, to show how these programs, the Medicare program, has evolved so significantly over an extended period of time. The landscape in 2002 would be unrecognizable in doing a projection in 1982, and similarly in 2022, it's just vastly different than the program that we saw in 2002. So with that said, there's a high degree of uncertainty, not just for how these programs, how this program will project out over time, but in fact for what this program will actually look like over time. As I mentioned at the top of this presentation, there is often legislation that materially affects these programs. Part D was created about 20 years ago. The managed care payments that are coming through here were drastically changed at that point. The Inflation Reduction Act just last year significantly changed the way Part D and Part B drugs are going to be ultimately paid. So there's just a whole host of uncertainty as to what these programs will look like in any extended period of time. Now, that said, it is still important to get an understanding for what the expectations of these programs are going to be under current law, to truly understand what the financial implications of different policies are, or the expectations under current law. So that's one piece from here. Two, you could just see as this program's evolved from 1982 to 2022, we've had a nearly tripling of the size of this program, I guess 2.5 times, with respect to the share of GDP. So this is just a much more significant program to the economy, not just to the seniors, the 65 million seniors that depend on this for their health benefits, but it's also a large and significant share of the overall, not just health economy, but economy as a whole. The last point I'll make on this slide is just something that struck me when I was looking at this, hopefully with fresh eyes last night, is the change in the managed care piece and the Part D piece. If you look, from 1982 to 2002, you could barely see the managed care piece. The private side of Medicare 40 years ago was barely observable. In 2002, that pie is worth, that slice is worth about 15% as the managed care slice in 2002. In 2022, the managed care and Part D, this is now the private side of Medicare. These are the part of Medicare that's being operated or that's being provided through private insurance companies, is up to 57%. There's just a major shift in terms of how this program has been delivered. It has historically was a predominantly fee-for-service type of arrangement, and now it is largely the majority provided by private organization. Even the non-private organization parts that there's trying to move away from some of the fee-for-service pieces, even in the inpatient and physician and outpatient services through some of the value-based care. But just wanted to at least make the point that the impact and presence of private insurance in the Medicare program has changed significantly, and is now just a major piece of this program. So top line, the key headline that when someone hears that the trustees report is out, they typically say, okay, what's the depletion date? The depletion date this year is 2031. That is 3 years later than last year's report. Largely, the improvement in the depletion date is twofold. There's two pieces to this equation. There's revenue and there's expenditures. Both are improved. The expenditures are more significantly improved in the short run, so that the expectation over the next decade or so is that expenditures will be lower than estimated in prior's report. And the amount of income that's expected is also expected to be higher. That's in part due to some of the underlying economic assumptions that are used in the report. Another key impact, and we'll get into this in a little while, are just the effects of the Inflation Reduction Act, the IRA. IRA introduces some cost controlling measures for drugs within the Part B and Part D program, including some direct negotiations. The Part B drugs get will start to, the effects of those negotiations will be realized in 2028. And then on the Part D side, there are some sizable benefit improvements. Most notably, a out-of-pocket limitation for Part D beneficiaries. So those with higher expenses, higher drug spending, will have a full limit on how much they're going to be required to pay for their drug coverage starting in 2025. There is also going to be drug negotiations on the Part D side, so we'll see some effects of that beginning in 2026. The fact that the benefit improvements take place first, I'm sure that will not surprise Joe. That first are the benefit improvements, and then the effects of the negotiations will kick in later. So as a result, we see increases in expenditures in Part D through 2030. And then we're going to start seeing some decreases in Part D expenditures in response to some of these IRA provisions, beginning in 2031, and then throughout, the balance of the projection. last piece that I'll note here, I'll get into this, more of this in a little while, is just on the COVID-19. So, while COVID-19 has significantly affected the short-range financing that we've seen, some pretty significant changes in the underlying use of healthcare over the last several years. There's been more testing, there's been treatment of COVID cases, but more than offsetting the additional costs have been reductions in spending for non-COVID related care. And I'll get to this in the next slide. We've done a fair amount of additional modeling to try to understand and explain that. And so I might as well get there now. So while over the last several years we've seen, and I'm going to focus here on fee-for-service for a moment. MA generally follows fee-for-service, but we've got a lot of underlying details for fee-for-service. That's where a lot of our analysis was focused. So fee-for-service spending has been consistently below pre-pandemic levels, pre-pandemic expectations, even into 2022, as some of the effects of the pandemic have started to wane. Not just the effects of the pandemic directly, but also the effects on the delivery system. So what we've done is we've done a fair amount of additional analysis to try to understand some of those fee-for-service reductions. And we have three factors in particular that we've been able to identify to help explain some of those differences. The first is this lower average morbidity among the surviving population from COVID-related deaths. What does that mean? People that died from COVID generally were individuals that had more intensive health use prior to their contraction of COVID. So greater shares, it being institutionalized or having inpatient care, having other comorbidities, having ESRD. And so to the extent that that's the population that were most affected by these COVID-related deaths, the surviving population has less of those conditions. And as a result, there's just lower morbidity among that surviving population. And so that explains some of the reduced expenditures in the recent fee-for-service experience. Another explanation for some of this recent more favorable fee-for-service experience, lower than expected, is that there's been a greater share of dual eligible beneficiaries shifting into managed care, Medicare Advantage. Dual eligible beneficiaries generally have higher use than non-dual beneficiaries. And so to the extent that dual beneficiaries, a greater proportion of dual beneficiaries are shifting into MA than non-dual beneficiaries, the population that's remaining in fee-for-service is a greater share of them are non-duals, and therefore average spending is decreased. And another factor explaining some of the fee-for-service trends is that there's been a pretty quick shift of joint replacement procedures, so hip and knee replacements that have been in the more expensive inpatient setting to the less expensive outpatient setting. So we'll get into a couple of those in a little more detail later on, but just wanted to set the context of, let me finish out the slide. So while we're still experiencing spending below pre-pandemic levels, when we adjust for some of these factors, we are less below than where we were estimating last year. And as a result, when that gap between current expectations and pre-pandemic expectations is narrowed, we have a smaller gap to make up now, and therefore we have lower or slower spending growth, and therefore ultimately lower spending projections. So hopefully that's not too much in the weeds, but I'll be happy to kind of get into a little more, and we'll present a little more background on some of these details in a moment. So we'll start, to get to some of the more basic results. So hospital insurance, this is part A. So what is contributing to the 3-year improvement in the HI trust fund? Well, it's two things. We're doing better on income. So we've got over the, this 5-year window, 2022 to 2026, we've got about 8.3 additional billion dollars in income, and we have $97 billion lower in expenditures. Can get into a little more detail on some of these. It actually turns out that the income tends to increase as we go to even later dates, and so that becomes a greater share as you move further out, and the expenditures actually starts to narrow a little bit as some of the higher update factors from some of the more improved or higher economic updates lead to some higher expenditure projections. And so we actually see later on in the projections a little more income and a little less improvement in the expenditure side. On the SMI side, Part B, we see also the income side that's generally updated each and every year. The 2023 income you can see is notably different. We'll get to that in a little while when we talk about Part B premiums. But effectively, the 2023 premium that was actually implemented was lower than what was assumed in last year's report, and that's what's showing up there. But you can see on the expenditure side, we are consistently having somewhat lower expenditures, for the Part B program, and that's largely due to these other factors just on the current utilization, and we're expecting a slower bounce back to pre-pandemic levels, or lower bounce back. So now jumping back to the HI trust fund ratio, you can see where our income relative to our expenditures is. Just for context, to be in actuarial balance, for the short range, we would want to be at 100%. We haven't been at 100% in a long period of time. But you can see that there has been a sizable improvement in this relatively narrow stretch where income has improved, expenditures improved, and that's what generating this additional 3 years. This is the big picture on where do all of Medicare dollars come from, and just starting from the bottom, working our way up. There's payroll taxes that goes into the HI trust fund, the tax on Social Security benefits. The fact that their limits aren't indexed means that that becomes a greater share over time. Premiums generally follows the government contributions. The state and drug fees, there's some modest amount of transfers there. But government contributions, that's what fills in most of SMI. You can see that increases relatively significantly. And then the top piece is the deficit. The deficit is that amount that on the HI side, where the payroll taxes isn't adequate to make up, to be able to provide for all of the benefits. And so that's the amount that is currently not financed, and why we have a depletion date. HI, we can talk about that income rate and cost rates. We can talk about these things not just in depletion date in terms of trust fund becoming depleted in a particular year. We can actually come up with a present value. So how much would effectively we need to raise the current amount of payroll taxes in order to account for this actuarial deficit, to make sure that the fund would be adequately financed for 75 years. So it's just comparing expected income and expected costs to payroll taxes, taking a present value of that. You can see that we did have an improvement from the 2022 report, where that actuarial balance was effectively a deficit of 0.70%, and now it's a deficit of 0.62%. So we had a slight improvement there. And again, that's just an extension of somewhat better on the income side, but of more consequence, there's lower on the expenditure side for largely the same reasons that I've already discussed. I can't get too far in these presentations without mentioning that there are elements of current law that are at least the ability to be able to adhere to current law is at least in question. So there are things like, well, this is HI, so we'll just talk about the productivity updates. These are that for most HI services, the payment rate updates are increased over time by underlying economics, but then they're reduced by economy-wide productivity, which in the long run is estimated to be about 1%. To the extent that healthcare providers can't keep up with that, that would effectively be a deficit. And, the long range historical has been that these providers can basically match a productivity rate of about 0.4%. So if that 0.6% gap wasn't closed, this is just an illustration of what cost projections might look like to the extent that current law was not adhered to consistently in all years in the future. And you could see that the long-range finances could be very different to the extent that certain provisions were not adhered to. I'll try to keep moving forward through this. On SMI, you can see here the share of GDP. On Part B in particular, we saw the 2022 came in more favorably. We saw that on some of the earlier slides when we looked at the expenditures. But we also see that the 2096 is also pretty significantly improved. That's in part due to some of the Inflation Reduction Act impact on the physician administered drugs, having some constraints built into there. So there's some modest reductions there. On the Part D side, the 2022 isn't very interesting, but the 2096 is basically demonstrating that the according to the projections that are used by the Board of Trustees, the IRA is expected to have a significant effect on long-range prescription drug pricing, certainly Part D drug pricing. So that constraint is pretty impactful, and I'll have a brief slide coming up in a little bit on that. Another area that gets a fair amount of attention is on the Part B, is on the premiums. I'll probably skip over the Part D because there's not a lot of action happening there, certainly not in the next couple of years. But on the Part B side, we were at, in 2022, we were at $170.10. In last year's report, we were expecting to keep that level, but then increase to $175.10 in 2024. In this year's report, we know that the 2023 actually had a reduction, so down to the $164.90. All other things being equal, if to the extent that you had lower financing this year, you would think that would require additional financing the following year to basically make up for whatever reserves you were otherwise using this year. But to the extent that there was, that favorable experience realized in 2022 and even in 2023, even with that reduction in 2023, the 2024 Part B premium is projected in the trustees report to actually be $174.80. Two ways to look at that. One way to look at it is it's almost a $10 increase from the current level. Another way to look at it is that rate is lower than what that was being projected in last year's trustees report, even though the 2023 premium was reduced. Both ways are right, but the most important part of this is that the final Part B premium will be announced this fall, and will take into account even more experience for the Part B program. I'm going to go through very quickly because I've already drone on for an extended period of time. This is just a pictorial representation of what I was alluding to with respect to some of the IRA influences on Part D per capita spending. You can see that, for the next several years, the benefit enhancements, in Part D is going to cause us. This is comparing this year's spending, this year's trustees report, Part D's per capita spending to last year's trustees report. You can see we see some pretty significant increases as those benefit enhancements start working their way through. And then once those negotiations start to kick in, we see that turnaround. There are savings by the end of the period here, and as you can see from the long range GDP presentation I just went through, there's significant savings expected throughout the long range period. Dual beneficiaries, I'll do this one relatively quickly. I think I already actually summarized this. This just has a little bit of numbers to it. Dual share of MA enrollment. So the share of duals that were enrolled in MA, the share of dual enrollment in MA went from 20.1% to 22.9% from 2019 to 2022. And you can see on the bottom chart, at the same time, the share of fee-for-service enrollment went from 16.4% down to 14.8%. You could also see on that bottom chart that those 16.4% of fee-for-service enrollees that are dual beneficiaries in 2019 contributed 29.4% of total inpatient spending. When you have a significant reduction in that number of enrollees down to the 14.8%, they then decrease the amount of inpatient spending to 27.6%. And so you can see that we've attempted to quantify what those effects were, and that effectively the 2022 spending is 1.6% lower than what it would have been had the enrollment share stayed level at the 2019 levels. Try not to get too in the weeds here. This is the last one. This one's just an easy one to see. This is the number of hip and knee replacements that the green line shows what was done in an inpatient setting. Blue line is outpatient. Black is an ambulatory surgical center. We were initially looking at 2020 and just saw that spending was down, and inpatient spending, for example, was down. And we might have even looked at it in 2021 and said, well, inpatient spending is down. We could see that a good amount of that could be explained, or at least a portion of that can be explained, because during 2018, 2020, some of these services were removed from the inpatient only list. And as you could see, there was a fairly rapid shift of having a lot of these services previously performed in the inpatient setting, moved to the less costly outpatient setting. And so we were able to explicitly model these effects this year. There's always an implicit assumption that some inpatient services shift to outpatient as technology improves and some of that care can be provided. But this was one that we were able to more explicitly model it, and you could see how quickly these services shift. I think that is all that I had. It was a lot, and I went relatively quickly and densely, so I'm going to turn it back to you, Joe, to start your interrogations.
Okay, well, unfortunately, we're not in the same room, so waterboarding will not be possible. But we'll see how this goes. One of the hallmarks of Paul's presentation is that the analysis is really more in terms of percentage increases and numbers that may look kind of small to the average person. But we should keep in mind how much money we're really talking about. The Medicare program is going to spend probably about $1 billion this year. And It's higher than that. Okay.
Well, you said 1 billion. We were spending
I mean,
close.
a trillion,
Yeah,
trillion
we're
dollars. Sorry.
supposed to three billion a day, give or take.
Yeah, yeah, exactly. About $1 trillion. So that's the reason why, and this is not a question of Paul, it's just an observation. That's the reason why there's so much angst in Congress between Republicans and Democrats, both sides of which actually know, no matter what they say, that we're talking about a program that accounts for an enormous part of portion of the total federal budget and will grow very rapidly over the next decade, and is an integral part in the debt and deficit situation that we see ourselves facing. And so it's not surprising that the debate over whether there will be an increase in the debt ceiling is revolving to some extent around the Medicare program and around the Social Security program, and whether there's going to be any willingness on the part of politicians on either side to take actions that might ease spending or increase revenues for either of those programs. Now, we do know that President Biden in the State of the Union address got everybody to stand up and swear on a Bible that they would, of course, not touch either of those programs. I'm a little fearful that may be true, but I suspect that isn't really going to be the case. By the end of this year, there will certainly be some very large spending bill that will pass Congress, and part of that will rely on Medicare savings. Now, my concern is that Medicare savings will simply be spent on something else rather than end up truly being savings that are attributable to the overall operation of the federal government. But anyway, that's my editorial comment. I tend to be anybody who has heard me speak over the years knows that I'm very pessimistic about the political ability to take strong actions when it comes to spending money, especially in the Medicare and Social Security programs. Okay, so with that, one other observation that I would make, which has to do with Paul's slides about Part B premiums, and you left out a year that I think is a very important year. So in 2021, Part B premiums were $148.50, and in 2020, as your slide said, we jumped up to $170.10. That's a 14.5% increase from 2021 to 2022 for the standard Part B premium. And then in 2023, as your slide says, we dropped down to $164.90, which is a 3% reduction. That probably has something to do with another policy that the Medicare program had to deal with, which was the introduction of what might be an effective treatment for Alzheimer's disease. And so, Paul, I was hoping that you could just kind of run through the thinking, not the political thinking, but the kind of the analytic thinking about what happened with the decision by the Medicare program to limit access to the new Alzheimer's treatment to a select number of beneficiaries based on something called coverage with evidence development. Basically, what that meant was that people who would be allowed to get that treatment would be limited, and there would essentially have to be a great deal of data collection. These people would essentially be participating in something like a clinical trial to collect information on the effectiveness of this drug for the Medicare population. So maybe you could just run through a little bit about the actuarial thinking on what led to these ebbs and flows in the Part B premium.
Sure. So we're going back a couple of years on this one, but as you kind of alluded to, there was a new drug that was approved by the FDA. This was what in the summer of 2021, and at that point there was no Medicare coverage determination. There was very limited information about uh, what the take up for this new and very expensive medication would be. Um, Alzheimer's disease is obviously a very significant challenge for the Medicare program, significant, just a devastating disease for those that are going through it. And the idea of a potential treatment that could actually slow the progression is just something that we expect would have just a huge amount of interest in. This particular drug had limited effectiveness and had some side effects that were concerning. But at the time where the Part B premium rate had to be established, there was just a large amount of uncertainty around how many people would take this drug, what the coverage determination would ultimately be, how widely it would be covered, and how many people would cover for. When we established, so when the financing for Part B is established, there's only one crack at it. So that in that fall time period, there is only one opportunity, and it comes through the secretary. The secretary has one crack to get the financing right. And so when that financing is established, it not only includes what the expected costs are going to be for that particular year, but it also includes a margin for adverse experience. And in that particular year, there was a significant margin built in for potential adverse experience, additional spending for the program, on the notion that to the extent that if this drug was effective and was widely covered and widely used, at the very high price point it could have had an extremely important, large impact on the Part B financing. And if the Part B fund runs out of money, it won't be able to pay benefits.
So Paul, let's put some numbers on this. I believe that the assumption was that something like 5 or 6 million Medicare beneficiaries could potentially have been given the treatment in the next year. And I don't remember the exact price, but it was something around $220,000 for a full year's course of treatment, if I'm not mistaken. Is that right?
Something a little high on the price. I think it was like 56,000 was the original pass. But so the pool of Medicare population that we thought had some degree of Alzheimer's was the 5 or 6 million folks. We actually only expected, we had our point estimate was only maybe 100,000 would take this drug, and in actuality a lot fewer would. But the concern is always on the tail, is always on the what is the upside, and if of that 5 or 6 million people, if 2 million were to have taken it, what would that have done to the program? And that's effectively, how that margin, that because you only have that one crack at the financing, that's why there was that significant risk built in.
Yeah,
now, kind of turning it forward.
Paul, also, people don't generally know, when was the Part B premium set? It's normally set in the fall. I don't think people realize that, but when was that one particularly set?
That one was also done in the fall. I don't recall if it was the September, October time period.
Yeah, generally October. And the reason for that is that the premium has to be set in time so that the machinery can actually extract the money from Social Security payments. So that takes a bit of doing, given the sad state of computer programming basically in the federal government. It's hard to find a Fortran programmer when you really need one.
I was going to have two more comments. I'll have a third comment based on that last remark. So just so the way this actually gets withheld is it actually needs to get loaded into the Social Security system that starts withholding. That January 1st, 2022 Part B premium actually gets withheld out of individuals' December Social Security payments. And so the idea that that has to be loaded in November is not too unreasonable from even my government standards. So that's one. Two, on that particular year, there wasn't that coverage of evidence determination wasn't actually done until early the following year. So it wasn't until I think it was January 2022 that decision came out. And so just when you deal with that uncertainty, you just have larger risk and you have larger margins that are required. I think three, the last point I'll have on this one is that what does this mean looking forward? There's a lot of promising treatments that are in various stages of pipelines. I think this highlights that to the extent that there is at some point in the future, a widely available, effective, and highly utilized and potentially expensive treatment for this particular disease, that in and of itself could put some significant pressure, not just on the program, but on the premiums and cost sharing and the like for those that will ultimately be using this drug. So I think that is I don't know if it's a cautionary tale, but it just an observation that it didn't, we didn't see that result from the 2022 experience, but at some point in the future, and it may be sooner than we might otherwise expect, there might be an effective treatment, and that could have some pretty significant consequences from a financial perspective on the other side of the potential huge benefits for the population.
Right. I think that's a really important point. It's also not just that particular disease and that particular class of drugs. I mean, we are already in a world where there's tremendous improvements in our understanding of the biology and the medicine and the science of treating diseases that are typically more common in the senior population than among younger people. And so we have the classic kind of good news, bad news story. It's two sides of exactly the same coin. The good news would be effective treatments. The bad news would be somebody's got to pay for it. And I think this the part about somebody's got to pay for it is the part that I think the political system has the greatest difficulty dealing with. No, I'll take that smirk as an agreement, Paul. You don't have to say a word.
For the record, I did not say any words.
Let's see. There's a question from the audience, and let's see. I want to get to the audience questions. I'm going to try to interpret this question. This is a question about Medicare Advantage. As you pointed out, Medicare Advantage enrollment has really grown substantially, and I think the rate of growth really accelerated in maybe the last 10 or 15 years for lots of reasons. And so I think this question really has to do with whether the increase in Medicare Advantage in terms of beneficiaries is having a positive impact on net spending in the Medicare program. And if it is having a positive impact, however one measures that, has that been taken into account in the projections? I think the last part of that question is, whatever the impact is, it's obviously being taken into account in the projections. But what's the actuarial view about the longer term impact of Medicare Advantage, and also whether enrollment as a percentage of the total population will continue to grow as we've seen it in the last few years?
So there's clearly been significant increases in Medicare Advantage enrollment over the last, as you say, probably decade has been where we've seen the fastest increase. Um, uh, there is an expectation that it will continue at some point. Markets get saturated, and you get to the points where it's seeing in certain markets where it's challenging for those penetration rates to increase further. And so we think at some point there is a cap. We have been consistently underestimating the pace of that growth. The MA markets are extremely strong and continue to be very strong. So we have increased those projections over time, and we do expect to be some continuation, granted, but not at the rate that we've experienced over the last several years, decade. What does it mean for Medicare spending as a whole? We need the CMS Office of Actuary don't have a formal estimate to that question. Others like MedPAC have done a lot of work in this area. Say something, been consistently saying that individuals in MA, when you account for all factors, might cost 1% to 5% more than in the fee-for-service program. Aware of other estimates with a fairly wide range around that. And the final part of your question are the factors taken into account into the projections, then I would say as best we're able to.
Right. Let's see. We have very little time. I wanted to also ask another audience question, which is really a policy question, and I will respond to it to a very limited extent, which is that this person asked, what would be the impact of changes on benefits received by households? I should start at the beginning. Given today's news that Social Security benefits will be cut in 2034, barring program changes, could we address possible program changes in the Medicare program, and how long they could be expected to defer cuts? And I think this is a question that sort of assumes that reductions in either program expenditures in Medicare or increases in Medicare revenues will be somehow transferred to Social Security program. So my first observation is that's not how current law works, but that's always a possibility. On the other hand, since Medicare is obviously not in great financial shape, I wouldn't expect that any actions taken to relieve the fiscal pressure in the Medicare program will then somehow translate into savings in Social Security. I think that Social Security, that's a totally separate issue, and will have to be dealt with on the basis of the structure of Social Security benefits and payroll taxes and other policies that might come down the road that don't now exist.
So I'll just add on to that, Joe, just that's the fact that we go through this process each and every year where we highlight the potential depletion dates of the respective programs. It is exactly to be able to provide information to policymakers so that they have the ability to avoid the situation where, yes, it's currently projected that HI is going to get depleted in 2031 and OASCI 2033, 2034, depending on how you measure it. The expectation, we've never gotten to the point where there's been inadequate finances, revenue, assets in those trust funds to pay full benefits on time. The expectation or the hope or the anticipation is that one of the values of these reports is such that policymakers have that information so that we do not get to that point, so that so those benefits aren't being provided, full benefits aren't provided timely. It's mentioned often in the trustees report that timely action is necessary, and policymakers need to work together.
Right, and unfortunately, we've had years where timely action could have been taken and hasn't been taken so far. We haven't really discussed the Medicare funding warning. This is the 7th year in a row where the the trustees and the actuaries have to warn the government, the Congress, and the executive branch that action needs to be taken. And 7 years in a row, we haven't seen much action along those lines. One last point from a colleague who asks a very good question. When will there be a Medicaid actuarial report? I know that there was, at least for a brief time, there was a Medicaid report that came from your office. So will we see this again? And will there be a kind of a thorough actuarial review of the program?
Yes.
I see. Well, okay. So maybe we will have to wait until Congress acts on serious policies before we see that Medicaid report. I hope it'll be before then.
I can almost guarantee it.
Okay, thank you very much. Well, I want to thank everyone for sitting through this informative and complicated discussion, and look forward to further discussion of Medicare and Medicare policies in the coming weeks and months. So thanks to Paul, thanks to everyone. Have a good afternoon.